Welcome. Thank you everyone for joining today's webinar on nerve retraining. We appreciate you taking this time out of your lunch hour. Our speaker today is Dr. Rohan Jatwani, Assistant Professor of Clinical Anesthesiology and double board certified in anesthesiology and pain medicine. Dr. Jatwani earned his medical degree and MBA at Tufts University School of Medicine. He completed an anesthesiology residency at New York Presbyterian, Weill Cornell Medical Center, Hospital for Special Surgery, and Memorial Sloan Kettering Cancer Center. Dr. Jatwani finished the Pain Medicine Fellowship at Harvard Medical School, Brigham and Women's Hospital, where he worked with pioneers to learn advanced forms of pain management and minimally invasive treatments. Dr. Jatwani is the editor-in-chief for the Journal of Medical Extended Reality and the Nanette Laitman Endowed Scholar in Extended Reality and Artificial Intelligence. At any time during this webinar, please feel free to put your questions in the chat.
Thank you so much. Thank you so much, Patricia and Janice, for setting this up. And thank you so much for our audience. I'm a practicing physician myself, so I know how much it takes to take an hour out of your day, specifically during lunchtime, to come to a talk. And so I thank you guys for learning a little bit about how my slice of the world works in medicine. I apologize in advance. My cat, it may make a couple of appearances on screen, but I find that to be quite endearing, actually, probably more than anything else. So as Patricia mentioned, my name is Rohan, or Dr. Jatwani, whatever meets your fancy, and I am a pain medicine doctor. And a part of my training involved really diving deeply into this question about what is pain. And I think it's an interesting one because, to be fair, we don't have a lot of specialties that are based around a single symptom. We have brain doctors, we have bone doctors, we have all kinds of heart doctors, but it's actually fairly rare to find an entire specialty based around a single symptom. And I think what I've learned over the years is a part of the reason that may be is because pain itself as a symptom can be so complex. And yet it is probably one of the most common, if not the most, maybe in the top 3 most common reasons why anyone sees a doctor. So what I often tell a lot of my residents, medical students, and fellows who I teach is, you may not do a pain specialty, but for sure, if you see patients, you are a pain doctor, because you're going to see patients who are in pain as a part of your career. And there are very few specialties in medicine that get away from that. So more than anything, I want to talk a little bit about sort of new concepts in this thing that we call nerve retraining. And the other thing I'd like to do, if nothing else, is empower folks like yourselves, healthcare practitioners, with tools, frameworks on how one should see pain and how should one think about pain. And I'll be honest, a lot of these things were things that I never learned in med school or residency. It actually took me fairly deep in my fellowship to start really thinking about what pain is and how it works. So if we start with just what is pain, right? The International Association for Pain Management sort of defines pain as a, quote, unpleasant sensory and emotional experience associated with actual or perceived tissue damage or described in terms of such damage. And that's kind of what we read about in the textbooks. But that pretty much says everything and nothing at the same time. I think one of the key moments that was pretty defining in my career as a pain doctor is when I sort of started to understand that we, in common parlance or vernacular, use the word pain pretty wrong most of the time. And again, I made it through most of my training without realizing this little nuance. So when we talk about pain in sort of common parlance, we talk about what we believe is like a signal coming from the body to the brain. And there is a word for that, but it's not pain. So a signal coming from the body to the brain is what we often refer to as nociception. Pain is a little bit more complex of a definition. So pain doesn't just refer to the signal that may come from the body to the brain after we say stub our toe or get a paper cut. It also discusses and has a fairly deeper meaning about how that signal is interpreted, and then how that interpretation is then relayed back to the body, which is to say that nociception is a ascending pathway, and pain is inclusive of both a ascending referral-based pattern and then a descending pathway. And there's a lot of nuance to what that means, but certainly one of the ways that we sort of develop a framework for pain is by trying to define it. So every patient that I see, doesn't matter whether I'm on the regional service as an anesthesiologist one day doing nerve blocks for surgery or after surgery, or if I'm in the clinic one day seeing patients who might have had pain for 50 years. I am always walking in asking the same question. What is this patient's pain? How can I define it? How do I put it into a definition that makes sense for that patient? And in 2024, we've gone through a lot where we've tried to figure out sort of common terms for how we describe large concepts in pain. The first kind of pain is a nociceptive pain. This is the pain that I think most of us are really familiar with, because nociceptive pain is a paper cut. It is a broken bone. It is inflammation of a joint. It is something that is red. It is something that is very localized. It can be something, people used to describe it in terms of visceral versus somatic pain, but these are pain that comes likely from an ongoing inflammatory process in the body. A neuropathic pain is where things get a little bit more complex, but this is pain that originates from nerve signals. So this is sort of where a lot of pain management bread and butter tends to exist. Neuropathies like diabetic neuropathy, a herniated disc in the back that creates a form of radiculopathy, some form of pain that exists in a signal where a nerve that should be turned off is not turned off. And people describe it in terms of electricity. Sometimes they describe it in terms of burning. So people can have, kind of ongoing signals from various nerves, both small all the way to very large. So small being something like a small fiber neuropathy, large being something like, if you think all the way to the very end of how this progresses, you could have a lateral thalamic stroke that results in, a pain symptom halfway through the body, or like on one side of the body. The last form of pain is a term that most practitioners aren't very familiar with, and it's one that we've started to use in the pain community over the last few years, but it has really helped in terms of helping me frame what a pain syndrome can be. And that's nociplastic pain. Nociplastic pain refers to disorders of pain processing. So many of us who deal with pain patients, and those of us who don't, can run into patients who have whole body pain, or pain that seems to be linked to different symptoms, whether it's IBS, headaches, fatigue, menopausal symptoms, period-based symptoms. So there are lots of different pain disorders that tend to fall into patterns that are very hard to describe in other terms. And nociplastic pain at its core are disorders of pain processing. The way I often describe it to signals is that you may have a chronic pain signal coming from the body to the brain, but somewhere along that pathway, the volume buttons can be turned all the way up. And things that may not be painful for other patients are very painful for you. And what makes my job kind of interesting and exciting is that often a pain syndrome can be all three at the same time. So I think of it in terms of every time I see a patient trying to define on an XYZ axis where their pain lives. Because certainly patients who can have, complex pain disorders can have underlying diagnoses like Ehlers-Danlos syndrome or fibromyalgia, which would tend to be more nociplastic in nature, but they may also have a herniated disc in their back, or they may also have very bad, facet joint pain. So a patient can have all three pain symptoms pain syndromes at the same time. The question is, I often ask myself is what's leading the pain syndrome and what's following, and how can we develop a plan for each of these things? Which brings me to my next point. How do we approach pain? Well, for a long time, it mirrored a lot of what you see on the screen. So, for decades, pain management was really defined by medication management. And that had its upsides and it had its downsides too. And one of the main downsides was this. We saw that, in the late 90s to early 2000s, as pain management really started to center around opioid based, specifically full agonist opioid based practice, we saw a increase in the amount of addiction going on in society and ultimately in the amount of overdose deaths in society. And it's a very deep discussion, a very nuanced discussion to try and understand the role of opioids in pain management. Certainly that could be an hour topic in and of itself, or maybe even a day or 2 days worth of topics to cover there. But suffice to say, what I have sort of taken from that as a anesthesiologist who utilizes opioids every single day in my practice as an anesthesiologist and occasionally in my practice as a pain physician as well, is that um, pain medicine at its core really doesn't serve patients well when the answers that we have aren't very nuanced. So if every pain sort of becomes or if there's a solution that we have where every pain is solved by the same solution, that sort of is where we get into trouble. I think that pain management at its very core requires nuanced, deep discussions with patients. It requires a lot of listening. And if I had to pick a North Star, if I had to pick a way in which we can see a better form of pain management progressing over time, it would come down to the fact that when we think about pain, we are thinking about three different syndromes that may be happening simultaneously, and each of those syndromes may require its own treatment. And if you're trying to treat all three syndromes with the same medicine, it may not quite work. So the way that I often train our fellows and our residents is to think in a very multimodal way. There may not be a single silver bullet for every patient out there, but we need to keep on trying and exploring different types and different concepts until we find the right form of medications, alternative therapies, um, interventions, procedures, devices, all that work for the same patient. And a patient needs to know coming into this that there's a lot of complexity to this and there may not be a simple solution. Now, ever so often I do see a patient who has a very simple pain syndrome and a simple injection is going to fix it, and then I never hear from them again. But to be fair, that is not most of my practice. Most of my practice is based around this concept. So when we think back to kind of understanding that concept of what is pain, what is that way in which pain can become a reference-based disorder, right? The way I kind of think about it is based on this paper that was written by Todd Maddox's and Beth Darnell's group, earlier this year, which is if you look at the screen, you'll see kind of two brains up at the top of the screen. The first brain highlights parts of the brain that we most associate with learning, right? So you can see parts of the brain that are lighting up are things like the prefrontal cortex, the somatosensory areas, the amygdala, which is associated with fear and engagement, and in habit formation, which is the cingulate gyrus. Again, this is a very complex topic. I'm not trying to turn this into a deep neuroscience talk, but if you look at the other part of the screen, you'll see the parts of the brain that we most often associate with pain. And if you put those two areas together, you will see an incredible amount of overlap. And what that has really shown us over the past decades of doing a lot of neuroscience research about pain is that pain can become a learned disorder, right? So the way I often describe it to patients is imagine a world in which you spoke no Spanish, and I put you in Spain into a remote region where they spoke nothing but Spanish. I bet within a few months, the parts of your brain that speak Spanish will become those neuronal circuits will become pretty hardened, and you'll get very good very quickly at speaking Spanish, which is the basis for why a lot of college students go on abroad semesters. The same can actually be true of pain. If the body develops a chronic signal from, say, the foot to the brain about chronic pain that's happening, whether it's neuropathic, nociplastic, or nociceptive. Over time, that learned pattern of behavior can become ingrained where even if the initial injury is taken away, that 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 reference of pain, that almost that memory of pain in those deeper areas of the brain can still continue. And the best sort of disorder that we have to think about this, right, is phantom limb pain, right, where a patient will get, say, an amputation, and the patient will continue to feel a reference of pain along that nerve path, even if the nerve is no longer present. And so I often tried my best to educate patients that pain is a learned behavior as much as it is a chronic signal beyond our, that just a signal from the body to the brain. Which brings us to the penultimate point of this presentation. If pain is a learned behavior, is there a process by which we can unlearn it? Is there a way to retrain our nerves and our brain for pain? And at this point, I would like to stop to see if there are any questions from the audience, just that we've covered a couple of big frameworks and to see if anyone has any thoughts before we move forward. Any questions from the audience?
Yeah, please feel free at any time to put your questions in the chat or using the Q&A feature. I think we can continue, Dr. Kartwani.
Excellent. So, my life has kind of lived in patient presentations and thinking very deeply about every patient's specific pain syndromes, which is why my favorite part of these presentations tend to be the case studies themselves. So I'm going to present a case study of a patient that I saw about a year ago. I've changed the details enough so that it's not specific to any patient, but there should be similarities that maybe you've seen in your patient panel as well. So case study number one, I entitled this, "My Body is Broken." So I met a 62-year-old female with a history of a lumbar fusion from L1 to S1. It did not happen all in one go. The patient initially started with a single fusion at a level L5S1, but after that level had been fused, the patient continued to have worsening pain, and ended up seeing the same surgeon who then diagnosed her with, post-junctional kyphosis, ended up doing the level above, and then had worse pain even after that fusion and went to a third surgeon who wanted to revise, and ultimately the patient ended up having a pretty large fusion from L1 to S1. When I saw her, she was wheelchair bound. And I was not the first pain doctor that she had seen. So she had seen 3 or 4 other pain doctors here in New York City. And going through it, she said she had, quote, failed every pain medicine. So this includes medicines like gabapentin and other anticonvulsants. This includes medicines like amitriptyline or Cymbalta, which are norepinephrine reuptake inhibitors. This includes even opioids. So she had been trialed on things like tramadol previously and oxycodone and had worked really hard to wean off of that. And she had also failed various pain interventions. So she had tried everything from epidural steroid injections to radiofrequency ablations, and believe it or not, had tried and failed 3 different spinal cord stimulators. So in that, what that means essentially is that somebody had trialed 3 different versions of technology to basically implant electrical devices in the epidural space of her spine to see if they could decrease the amount of signals. She had finally gone on to see another surgeon who had sort of said, maybe we need to extend the fusion beyond where it's currently been extended, and then came to me for a second opinion prior. And in seeing this patient, the one thing that she had mentioned to me over and over and over again is that she felt that her body was broken, that her body had somehow betrayed her, that before any of this had happened, she felt like she lived a normal life, and now normalcy was just trying to get through the day in the wheelchair. And this is a very common presentation that I see in my clinic all the time, of patients who have had a lot of different treatments and failed a lot of different treatments. But the one theme that keeps on coming up over and over again is this notion that there is something wrong with my body. Like, I just can't make sense of what's going on. And what that tells me is that there's a deeply nociplastic etiology for this pain. At this point, the mind-body matrix is fairly warped. And rather than considering this as a therapy where we need to just focus on, say, an intervention or another surgery, we also need to start thinking about the larger concepts of how we get you to unsee this way that your body is broken. Maybe the fact is that there is things that could be done to help you, but if your mind is so warped that you can't make sense of how you even see yourself, your mind body matrix, some of that sort of falls apart very quickly, where no real intervention will be that helpful. So it brings us to an area to start to consider things like this. This is Snow World. Snow World was a application that was developed in Hunter Hoffman's lab back in the late 90s, early 2000s. And it was developed with a very specific use case in mind. One of the most painful procedures that we do here in the hospital is burn dressing changes. So patients who get burn dressing changes often have high dose requirements for medications at baseline. They have extensive burns, and the act of just changing the dressings on the burns can be so painful that it requires deep sedation with medication. But what Hoffman's lab found out was if you put a headset on a patient and you brought them to a world filled with ice, and you distracted their brain by playing a game that you saw earlier where you're using your head to kind of throw snowballs at other objects in this snow world, what they found was quite incredible. The amount of medication that you needed to get through that burn dressing change got lower and lower. And what this showed was that minds that were put into virtual worlds had the ability to kind of experience pain differently. And so this brings us to a very popular new therapy that's being explored called virtual reality therapy. And the question that we start with is, what is virtual reality, right? Because is it simply the act of wearing a headset that makes virtual reality virtual reality? And I would argue no, and most of us who study this in this field would agree with that. Virtual reality is the specific three things needed to create a type of patient or consumer experience. The first is immersion. And what immersion essentially means is that your mind is immersed in a 3D world such that the world that you see ceases to exist, is an objective change in your reality. Presence is a very subjective meaning, a term. And what essentially it means is that your mind no longer has a connection with the outside world that once it wore the headset. So whereas immersion is your objective immersion into a 3D space, the idea of presence or your mind accepting that new world is what we would define as presence. And the last thing is interactivity. So you need to be able to interact with this 3D world in a way that's different than the world that you exist in wearing the headset. So in the previous example, you saw that you could move your head around and throw snowballs at objects. That would be an example of interactivity. And all three are necessary in order to create a virtual reality therapy. Now, to give you an example of how far virtual reality therapies have come along, so Hoffman's lab created Snow World back in the early 2000s with headsets the sizes of, microwaves. Um, these days, things have gotten a lot better. The headsets have gotten a lot smaller, and the types of simulations that you can create are much more complex. So here's an example of a simulation that I did earlier last week, where I'm wearing a headset, and in real time, I'm flying a plane that is landing here in New York City, where I'm currently based out of. Now, I control this plane entirely, and the world that you're seeing is a world that's being entirely rendered as I land this plane. So, it's a lot smoother in real life. Like, it doesn't have that same clickiness that you're seeing on the screen, but it's hard to record and do something in real time as it's rendering. But every building is being created as I'm dropping into the space, which is kind of incredible to think about that we have the simulation technology available to us, because this was done. Like, you can see me landing right now on the rooftop of Weill Cornell Medical Center, but this was done with a sub $500 headset with a technology that costs about $10. And that's how much this field has grown over the past few decades. So going back to our initial hypothesis, right, which is pain is a learned behavior, and can we alter that pain or retrain that pain using things like virtual reality? Well, one could argue that yes, because Hoffman's lab then did follow-ups for those same type of patients, the burn patients, and they saw that with VR, areas of the brain that we most associate with pain that I showed earlier were not lighting up as much in MRI machines when the headsets were on and they were in Snow World. And what that tells us is that there is a profound effect for the things like immersion, presence, and interactivity that can change the way that the brain processes and refers to pain, even as it's acutely happening to patients in something like a burn dressing change. So what this results in, right, is going back to our patient, is that I prescribed the patient a virtual reality therapy. And this virtual reality therapy I prescribed to her was one where she was sort of asked to wear a headset for about 20 minutes a day. And in that headset, I had her look at a specific simulation called TRIP. TRIP is best to define it as you're about to see is a consumer-based technology, but what it really is a mindfulness training application that I call ketamine without the ketamine. It puts your mind into fantastical places where you're able in 360 to look at images that are quite profoundly opening for consciousness and allow one to basically meditate and achieve mindfulness in a very practiced way that isn't just telling your patient go and learn how to meditate. It's guided, so I don't have volume on this, but there's actually breathing exercises built into it. You can change locations and learn how to meditate in the mountains of Tibet. You can do this all from your home, wearing a headset, timed for a certain amount every single day. And what was incredible was watching the patient over the course of the few months come back to me and say, so I tried different forms of virtual reality therapy. I liked the games most of all because I thought they were distracting. But it was funny because in the virtual spaces where we were learning how to be mindful and meditative, I began to sort of get a little weary of all the thoughts that were coming to me at that time. And I began to realize that my thoughts and my body were two different things in these kind of spaces. And I was able to learn how to listen to my thoughts about my body being broken without actually feeling the result of that as a pain in my body while I was in this space. And that kind of profound realization is one that I have not seen very possible with other forms of technology. But we're not the only ones looking at this too. That same group that I showed earlier, Maddox's group and Beth Darnell's group out of Stanford did a 2-year study looking at a in-home virtual reality program for nothing quite as extreme as some of the cases that I was doing, but just something simple that we see in a lot of patients, chronic low back pain. And what they found was that over weeks of I believe it was either 6 to 8 weeks of continuous sessions, daily sessions in the headset, what they found was an effect that lasted as long as 18 months post. And this was published in one of our bigger journals for pain management called Regional Anesthesia and Pain Medicine. And what was great about this study was not just that they had the patients go through the VR program they created, they also had them go through a sham VR, which is defined as wearing a headset but not having the presence, immersion, and interactivity that we associate with true virtual reality therapy. And they saw a difference. So it wasn't just the act of wearing a headset or being in the trial, it was truly something going on with the programming that they created that resulted in, even after the session stopping, the effect lasting longer than that. And that is kind of the thinking that we associate with nerve retraining or brain retraining as opposed to just a distraction-based therapy. So at this point, I'm going to stop for another round of questions to see if anyone has any thoughts or concerns or questions.
Hi, Dr. Jotwani. There was a question that came in earlier, and I'll just read it. Can the same concept be applied to recalcitrant pruritus?
So we have done, actually in the literature right now, there are a number of N of 1 trials coming out. So I have seen recent studies for chronic obstructive pulmonary disease where patients have difficulty breathing. There's a group at Cornell that's interested for trying it for dysphagia. I have not seen anything specific for pruritus, but I would go so far as to say is if there is a chronic signal element where patients are itching even though that there's no active ongoing inflammation, and we're trying to change a behavior through various practices similar to chronic pain, it would, given the risk benefit of a therapy like this, I would say it would be worth trialing.
Okay, the next question is, how do you categorize visceral pain?
So visceral pain, I would see this is where sort of older definitions become a little tougher, because visceral pain, which most commonly we think about as hollow organ pain, right, can kind of fall into different categories. Cancer pain can be its own category of visceral pain, but I would categorize it mostly within a nociceptive form, knowing that visceral structures can also engage nerves and cause sympathetic type pains and have a neuropathic component, and that visceral pains can clearly have a nociplastic component as well, because organ damage can result in chronic signals that are disorders of pain processing. Um, and so a lot of us, are trying to sort of get away from calling anything one very specific pain, but kind of seeing things through the lens of all three types of pain syndromes. But most classically, I would say visceral pain falls into a nociceptive type of origin.
Okay, and the next question is, similar question for neuralgia paresthesia. How have found little info on alternatives besides PT and meds?
Yes, and that's something that we have seen fairly often. I will actually hold off on answering that question because there's a second case I'm about to talk about that may be helpful there. But for that specifically, we can think of sort of larger chronic pain type retrainings through virtual reality therapy. But there's a new therapy I'm going to talk about upcoming in the next few minutes that may also answer that question, because that is a very specific nerve related question that we may have a more specific nerve related retraining program for.
And the last question, how many patients get dizzy or nauseated when the headset is on and program is started? What can you do about it?
Yes. So the first thing you can do very simply is you can just take the headset off. Usually that helps. Sometimes patients do benefit from, medications that they can take. But to be fair, I have not seen many of my patients in 2024 have the same levels of dizziness and headaches that they used to have, or nausea, when the programs first started. The headsets have gotten exceedingly better at this. I would almost go so far to say exponentially better at this, where we're not seeing the same rate of this. We do actually have new society guidelines coming out from JMedXR about what to do in the setting of nausea and dizziness. The easiest thing is this is a fairly easy therapy to abort. Patients can just take it off, and usually the side effects of it will go away pretty quickly. Um, and usually what I see is that if they do have any dizziness or nausea, it gets better over time. So as the body learns, or as the mind learns to adjust to virtual reality therapies, the first time they may have it, but usually by the end of the week, they're doing much better. Um, and the fact that this has become fairly consumer grade technology that anyone can go to just about any electronics store and pick up has really sort of touted that we're seeing much less side effects than we were 5-6 years ago.
Okay, that's it for questions right now. We have about 10-15 minutes left, so let's move on. Thank you.
Excellent. All right, case number two. So this was a case where a patient came actually all the way from a faraway state, a 34-year-old female with decades-long history of headaches. She had surgical decompression of occipital nerves, but had ongoing head pain and was unable to get off chronic opioid therapy. So imagine being 34 years old and you've tried everything for headaches, from Botox to the CGRP inhibitors, and at some point somebody had started her on opioid therapy. So I believe she was on high dose oxycodone, and really was unable to spend time with her 2-year-old baby, which those kind of stories really get to me and really make me think about, like, is there anything that we can do? In this case, it did look like there was some concern that she had occipital neuralgia, and after having nerve blocks of the occipital nerve, she would get better, but they would not last. And so there was this thought that by decompressing the occipital nerves, this would result in better pain. And it had to some extent, but it wasn't doing enough. So I think we had found a target here, but the idea was that even after decompressing the nerves, there was some element of chronic signal that was unable to be changed. And so this takes us back to kind of a very cool project that I did when I was a resident looking at history. So in historical times, actually ancient societies, specifically in the Papyrus of Ebers, had this one line that referred to ancient societies like the Egyptians using fish from the Nile, specifically electrical eels, around their heads to help with headaches. And we've seen this actually. So this is a picture dating all the way back to the Roman Empire. And if you look at B, you'll see, the tale of Tiberius, a man who had ongoing chronic 24/7 headaches. And you'll see the physician place an electrical eel over his head. And you can see that even though these were societies that didn't really understand much about concepts of electricity, certainly not about how electrons and protons flow, they were beginning to understand a little bit that there's something going on here where these headaches have some kind of electrical foundation and can be helped with certain types of therapy. Which brings us to certain concepts in neuromodulation. So, in the 1960s, Melzek and Wall first published the gate theory, which was this idea that if you implanted electrodes into the human body and they were creating a counter signal, the spine could only take so much signal at the same time. And if you close the gate through different kinds of electrical therapy, the pain therapies themselves could not, sort of make their way to the brain. And for a long time, this was sort of enacted through things like TENS machines, which you can see in the picture, even like spinal cord stimulators that were implanted into the body. And what I would say is in our first iterations of neuromodulation therapy, I really do think of them as distraction-based therapies. You're creating a counter signal, but you're not changing the initial signal at the level of the nerve itself. Which brings us to a new practice that we're developing here at Weill Cornell Medical Center, which is really centered around this idea of peripheral nerve stimulation. So what if instead of implanting a lead to create a distraction-based therapy around the nerve, you instead were implanting a lead near the nerve of interest and trying to instead retrain that nerve on how to behave. So we use a specific type of peripheral nerve stimulator, which is designed to only be in the body for 60 days. So we go to the operating room, we isolate the nerve, we create an electrical field around the nerve using a lead that's the strand of a human hair. A patient wears a battery pack that's hidden under their clothing for 60 days. And at the end of the 60 days, they come back to clinic and we just take it out right there and then. So the patient has no permanent hardware in their body. And for this particular patient, we had hypothesized so this is a scan that we created in 3D. We were able to highlight the nerves, specifically in this case, the greater and lesser occipital nerve, and think about how we may implant this temporary lead around those nerves to be able to create a counter signal that over the course of 60 days would change the activity inherent to the nerve itself. You may say to yourself, well, what happens if you remove the lead and the pain signals come back to the way they were? And while there is that risk, actually what we've been seeing is that the pain effects last much, much longer than after the lead is taken out. So for example, in this patient, which I believe we had removed her leads back in April, she is still pain-free today. And while we were in that 60-day period, we made it kind of our mission to get her off of opioids. So in having seen this patient recently, she is now off opioids and still occasionally having headaches, but they are intermittent and they're nowhere near as bad as they once were. Which is incredible to think that this has been accomplished with a temporary stimulation pattern. And we are not the only ones seeing this. So this was a article that was published in July of this year by Ryan D'Souza's group out of Mayo, which shows that if you compare temporary versus permanent peripheral nerve implants, you see that at the 24-month mark, the pain scores are relatively similar, which means the patients who had the permanent device placed into their body are at the same level of pain than the ones who had the temporary stimulator placed that was removed. And the incredible thing about that is that it tells us that neuromodulation therapy is evolving. And neuromodulation therapy is becoming more than just a Melzik and Wall gate theory based approach where we believe we're creating a distracting signal. There are deeper studies looking into the fundamental changes that happen at the level of the nerve itself and at the level of things like the DRG, the dorsal root ganglion, and higher levels of the brain that happen when you create these powerful electrical fields that allow the nerve to basically do something other than emit its chronic pain signal. And so this kind of work has been exceedingly exciting for us here at Weill Cornell Medicine. And going back to that question of um, neuralgia paresthetica, that is actually a treatment that we have because we can find the lateral femoral cutaneous nerve fairly easily under ultrasound. And we have done cases of inguinal as well as lateral femoral nerve cases where we've implanted the device near that nerve and allowed it to basically do something else than emit its chronic pain signal. Um, and so this area has become fairly exciting for us as well, and it's a therapy that, this concept of nerve retraining, one that we're offering more and more to patients here at Weill Cornell.
Thank you. We have a question in the chat. What is the recommended process, whether it be VR unit, program, and frequency, duration of utilization, for clinicians to guide patients to use this modality? And any recommended publications?
Oh my gosh, that is, I believe that's probably Ernest asked that question. That is an incredible question. Because that is something that we in the medical extended reality world are asking ourselves all the time. So um, it is a little bit of a wild west out there in that we have yet to codify the entirety of treatments. So, saying that we use virtual reality to treat pain is saying like we use computers to treat anything, right? It doesn't really mean that much unless you codify it, like the question was, into a specific program. Certain groups have come up with certain programs. So, for example, Applied VR actually has FDA approval for their program. Karuna Labs has another program that they're looking to submit for FDA approval for shortly. And many of us in the space are trying to make sense of, well, does that program extend to other kinds of pain as well? So there are tons of publications for it. I'm happy to send it out. And we are looking to develop guidelines for more generalized approaches. I have found that the one thing my patients are most sensitive to is cost. So my patients obviously want to get this therapy covered by insurance. It is coverable by certain things, like for example, the VA actually has an incredible job of getting their patients access. Medicare may cover some of these in certain areas too. One thing I've found is the patients who have commercial insurance um, tend to want to either try this through a physical therapist's office. So we have physical therapists that we know here in New York City do the therapies and incorporate it into their sessions. And there's certain ones who want to do it from home. So there's a couple of groups out there who will send the headsets to patients' houses and take them through that therapy. And it's a very creative process. The one thing I'll say is for the patient who really just wants to explore it on their own, the headset that I most commonly tell them to use is the one that's most available to everyone, which is the MetaQuest headsets. And I often tell patients, these are the kinds of headsets that are so simple to use that 10-year-olds can use them, and they do use them. And then I just tell them the apps to download and kind of how to get through those apps. So we're still figuring out exactly how to prescribe this therapy directly to patients. There are a lot of different options. I would say for right now, the easiest way is just to connect your patients with one of the groups that has a proven therapy and has written extensively about it. But in a few years' time, we will have a lot more literature looking specific recommendations for specific kinds of pain.
We'll take one more question. What options would you suggest for a patient with chronic degenerative knee pain that prevents ambulation who needs a knee replacement but is not a surgical candidate?
Yes, that is a great question. So that is a little bit of my bread and butter because I do see a lot of patients who fit into that category. In fact, just a few weeks ago, I had a patient who is in her 90s and due to various reasons is not a candidate for a knee replacement. For her, she had come to me after seeing a doctor who had already tried what's called a genicular nerve ablation, where they had done blocks around the knee to sort of silence or quiet down the genicular nerves going to the knee. And she had gotten some, maybe 10 to 15% of pain relief from the ablation, but not very much. And so the approach that we took was, if ablating the nerves did not quiet the signal down, is there a way that we could instead implant those temporary wires around the genicular nerves and then essentially retrain those genicular nerves over the course of 60 days? And I'm happy to say that, even, it was tough to see how, if we could retrain the nerves of a 90 something year old patient. But that patient has done exceedingly well after that treatment. And we took out the wires probably back in early March. And she's been doing much, much better. Um,
I see we have one more question. So, Dr. Barron, do you want to unmute yourself and ask your question? Dr. Barron? Okay, it looks like that's not available.
well, yeah, sure. Dr. Barron,
Um,
any questions?
I think I'll email you privately.
Sure. Absolutely. Yeah,
Thank
feel free. I see Dr. Green has said, do you know of patients younger than 10 using those headsets? Absolutely. In fact, Kate Donovan, who is the Chief Innovation Officer at Boston Children's, I recently had a discussion with her, and they're using a number of headsets in both in hospital and within their pain clinic settings for patients younger than 10. And so there are a couple of headsets that have been developed for that situation entirely, and specifically age appropriate programs. Um,
okay, it looks like we're at time. So thank you everyone for joining. Dr. Jatwani's contact information is on the slide. Feel free to contact him if you have any questions or if you need guidance on referring a patient. Thank you so much for attending.
Bye, everyone.
Take care. Have a great day.